Hello, my name is Lacey Goodman. This is the Cardiovascular Assessment. So it's the heart, vessels of the neck, and the peripheral vascular system. So the first thing I'm going to do before anything else is check the for jugular vein distension by checking the jugular venous pressure, or estimating it rather. So what we're going to do, I'm going to look for a landmark of the external jugular vein, which I do see is right here on the patient. I probably will not be able to see the internal jugular vein because it's too deep, but what I should be able to see is a pulsation on the skin if I look carefully, and his is right here above the supraclavicular notch. So what I'm going to do is take a straight blade, or in this case a tongue blade, and I'm going to find the highest point of that pulsation. I'm just going to hold this out horizontally, and then I'm going to measure in centimeters what the height of that is. And I'm at 1.5 centimeters. So that is considered within normal limits. It would be abnormal if it were over 3 centimeters, and with the bed elevated 45-degree angle. That's typically in heart failure. That's just typically something we see in heart failure. So now that we have determined our jugular venous pressure, we're going to be palpating the carotid arteries. So a couple of things you want to remember when you palpate the carotid arteries. You never want to do them at the same time, and you never want to do them too high up. If you do them too high up, you may stimulate the vagal nerve and cause a drop in blood pressure and heart rate. So you also don't want to push too hard. So you're just going to palpate. Okay, and then we're going to palpate the other side. We're going to do on both sides. Okay, the carotid pulse is equal bilaterally and +2. We use a scale of 1 to 3, 1 being weak and thready, 2 being normal, and 3 being bounding. Patient has normal carotid pulse. So now that we have palpated our carotid arteries bilaterally, we are going to, I forgot to mention, the upstroke when you're palpating it, which is how I determined that it was +2. We're going to be looking at the contour and amplitude. It should be smooth, a rapid uptake, a slower downtake in both, which there was. It's completely normal. Alright, next we're going to need to auscultate the carotid. You typically auscultate the carotid arteries in patients that are middle-aged or some who are at higher risk for cardiovascular disease. So what we're going to be looking for is the presence of any bruits. So I just need you to sit up, please. Okay, I'm going to be listening with my bell of my stethoscope. You're going to be listening. I'm going to be listening in 3 different places up on the carotid. You're listening right below the jawline, the mid-clavicular area, and the base of the neck. When I do this, I'm going to ask the patient to hold his breath for just a few seconds while I listen, so it doesn't obscure what I hear. So, after big deep breath and hold it in. Okay, exhale. Take another deep breath. Hold it in. Alright, good. So I did not hear any bruits, so that's great news. Okay. Now we're going to go ahead and lie straight back down. Scoot down like I want. Alright, so now we're going to be inspecting the precordium First, I'm just going to look at the precordium, make sure I don't see any pulsations that shouldn't be there. No lifts. Okay. I just completely read Oh, heaves or lifts. That's what I was trying to say. No heaves or lifts. Okay, so then everything looks good. I don't see any strange pulsations. So then I'm going to move on to palpating the apical pulse. So what you're going to do first is you're going to find the apical pulse. So you're going to find the second intercostal space at the edge of the left sternal border, and then you're going to come down 3, 4, 5, and you're going to walk your fingers over to the midclavicular line, and this is where you should feel the apical pulse. And I do feel it quite nicely, but for the sake of assessment, I just need you to slightly roll to your left. You don't have to do too much, but slightly roll. You're going to need to remember that you've just placed the heart a little bit further down, so just walk the fingers a little bit further down and feel the apical pulse more. And I do. That's great. Now I'm just going to use my hands to palpate for any pulsations that I didn't see on inspection. Okay, and I don't feel any strange pulsation. So next we would typically percuss in this area of the assessment, but we don't really percuss the heart. We usually use EKGs or chest x-rays to determine hypertrophy at this point, so we're just going to skip that. So next we're going to auscultate the heart and the valves, the valvular areas rather. So I'm first going to get to, I'm going to look at the second intercostal space and the right sternal border, which is going to be the aortic valve, excuse me. Then if I go to the left side of the sternal border in the second intercostal space, that's our pulmonic valve. And then I'm going to go down the next 3 intercostal spaces are the that's right where we would call Erb's point. And then when we get into the 5th intercostal space, that's the tricuspid valve. And then when we shift over to midline in the 5th intercostal space, that's our mitral valve. So first I'm going to listen with my diaphragm. I'm going to go in that same Z pattern that I just described. Okay, very good. In just a second, I'm going to do that all over again with the bell of my stethoscope. But in between, I'm assessing S1 and S2. I'm trying to assess the rate and rhythm of the heartbeat. Once I'm able to identify S1 and S2, I'm going to really listen carefully to make sure I don't hear any extra heart sounds like S3 or S4. And I'm also going to be assessing for any cardiac murmurs. I don't hear any on this patient particularly. Alrighty, then I'm going to do it all over again with the bell of my stethoscope. Okay. Very good. No abnormal heart sounds. Alright, the next portion is where we assess the peripheral vascular system, so I just need you to sit up for me. Can you adjust if I need to? No, okay. Not at least for the upper extremities. Okay, so we're just going to start with the upper extremities. So, and that's the arms. So what I'm going to do first, I'm just going to inspect. As always, we start with inspection. I'm going to be looking at the symmetry of the arms, the color of the skin, homogeneous color of the skin, any rashes or lesions. Then I want to come down to the hands and look. I don't see any clubbing. I don't see any lesions. The hair distribution is appropriate on the arms and hands. So then, now that I've inspected, I'm going to palpate. I'm going to palpate the temperature of the skin. It's warm but afebrile. Skin is smooth. I'm going to come down and on the hands I'm going to assess the nail beds. Like I said, there's no clubbing. And then I'm going to assess capillary refill, so I'm just going to squeeze down for a few seconds and then release. His capillary refill is excellent. It's back almost immediately, so there's no concern there. Alright, now that we've assessed that, we're going to go ahead and check our pulses in our upper extremities. So we're going to start with our radial pulses. You can see radial pulses are equal and +2 bilaterally. We're going to come up to our brachial pulses. Brachial pulses, +2 and equal bilaterally. Alright, and what else we want to do is to assess the epitrochlear lymph nodes. So it's going to be like he's shaking my hand, and with the opposite hand I'm going to come around and feel for any swollen lymph nodes in the epitrochlear area. And I don't. Do the same thing on this hand. No swollen lymph nodes. Alright, now we're going to move on to the lower extremities. So, let me move my camera angle a little bit. If you could put your legs together a little bit. Alright, again, we're inspection.